behalf on behalf of Bombay Psychiatric Society, welcome everyone to today's clinical meet on sleep psychiatry interface. It's a second meeting on the same topic, and today we'll be talking more about children. We're very happy to have the chairperson of the evening, Dr. Kersi Chawra. He is one of the most respected child psychiatrists in our city, I would say in our country. He's one of the well-known people out there. He has been associated with Bombay Psychiatric Society as he has been the past president of BPS. He has been the advisor to IPS. He is an advisor to IPS School Mental Health Task Force. He heads the IAPP College Mental Health Section. He's a consultant psychiatrist at PD Hinduja Hospital, Mahim Khar, and Sir H.N. Reliance Hospital. So he's one of the well-known psychiatrists who deals with children. So there's no one better than him to chair the session. Over to you, sir.
Thank you. It's a pleasure to be with Bombay Psychiatric Society again, and it's an even greater pleasure for me to introduce the two chaps who are going to be speaking on today's topic, which is an extremely important topic associated with sleep. I am absolutely privileged to be able to introduce Dr. Bhaskar Mukherjee. For those of you who have not interacted with him, he calls himself a student of psychiatry, the medical discipline dealing with the full working of the brain. He's most comfortable with molecular biology. For him, psychiatry is molecular psychiatry. So if you want to see him smoke coming out of his ears, we can talk about Freud and we can talk about psychologists, some of whom might be actually listening in, and we can talk about sociologists, and you will get a frothing at the mouth of Bhaskar. His main interest areas are actually treatment resistant in psychiatry and transdiagnostic understandings. He loves to understand and evaluate the pathophysiological basis of psychiatric symptoms, both macroscopically and microscopically. He goes from connectomics to genomics. And his life's goal, as he describes it, is to make psychiatry regain the master spot in medicine. And none of us can ever fault him on that. A spot reserved for the medical specialty dealing with the master organ of the body. Just as a little aside, we asked him for a photograph. He sent a photograph of himself astride a horse. So in the interests of being a little circumspect, we did not post it on today's invite. The second speaker, a lovely young lady, Dr. Manjari Deshpande Shenoy. She's done an MBBS, a DNB in psychiatry, and a fellowship in child psychiatry. Is passionately interested in child, adolescent, and young generation psychiatry. She heads a chain of child and adolescent guidance clinics, which are the in-laws child guidance clinics. This has branches in Mumbai, Vijayawada, and Visakhapatnam. She works with a team which caters to diverse academic, emotional, and behavioral needs of children. And she's the convener for the school mental health of the Indian Association of Private Psychiatry. Okay, a couple of ground rules. I'm very anal about time. Each of the speakers will get between 20 and 25 minutes. At the end of that, whether you like it or not, and however erudite you are, and however wonderfully you are talking, I will be forced to intervene and ask you to stop. There will be about 15 to 20 minutes of question answers at the end. Please put your questions in the chat box, and I will direct the questions to the speaker unless you actually want a particular speaker to speak. You will be constantly muted. At the end, if anybody wants to actually talk, then you can ask for unmuting, put a show of hands. But by and large, let the questions come from the chat box. Okay, over to you, Bhaskar. You have between 20 and 25 minutes. Thank you.
The biggest problem is if I was going to do a psychoanalysis of dream, 25 minutes would have been enough. But talking about neuroscience of sleep, it would take at least few hours. So I would skip areas and I would describe two areas of dream, because beyond that, if I try to explain, it would take much more than 25 minutes. With this warning, let me start the presentation. Hello everyone. I forgot to actually greet you. So I have to share my screen. Why Jagjot is coming and going, I don't know. So this is today's presentation. The neuroscience of dream. The second line is intentional. The interpretation of dreams in scientific way, without big C and without R's. I hope you know what is big C, and I am not going to elaborate. This was how the second interpretation of dream written. The first was written by Archimedes in 4th century BC, and then the second one. First one is actually better in scientific quality. Now, that which subject deals with scientific research and analysis of brain? It is known as oneirology. Oneiroi is the Greek god of dreams, and sometimes dreams are called oneiroi in Greek, and the name originates from there. What we are talking about today and what we would explore today, and a lot of things we are not going to explore today, are part of and actually mainstream of oneirology. If anyone is interested, they can get a good idea of this subject by Google search. So, as I have already declared, I am not going to explore dream as humanities. Then we have to explore it as scientific phenomena. And whenever we are describing a scientific phenomena, there are some basic questions. What is that phenomena? Why does it happen? How does it happen? And when does it happen? Starting from dream to behavior to brain function, if we study anything as scientific phenomena, we have to encounter these 4 questions. Now, what is dream? For a technical definition of dream, there is no standard definition of dream anywhere in scientific literature. Dream is to be, if I try to give a precise definition, it would be like dream is a visual imagery which happens when the animal is in a state of restful sleep. Now, why it happens? The why is not yet known. There are multiple theories, multiple hypotheses, each of which has been proved to some extent, and there are a lot of lacunae in them. One theory is primarily our memory and learning. These two processes happen during our conscious period, but they consolidate during our sleep period. During this consolidation, my video froze. Am I still in the meeting? Yes.
Yes, sir. We can hear you.
Yeah. Okay. So when our learning and memory acquisition happen during conscious state, but during sleep, they are consolidated in the brain. By consolidated means the deeper engrams, the synaptic branching, the synaptic strengthening, all these things happen during sleep. And for that, brain needs to play those imagery again and again. And that is the basis of dreaming. This is one theory. This theory has its proofs, has some logical problem, and has some lacunae. But again, I am going to give a bird's eye view, so I am not going into that. The second theory is more interesting. It says that our brain is intrinsically plastic. Not our means animal brain. Animal brain is intrinsically plastic. So, being a highly plastic organ, all the areas of brain are in competition with each other about the functional space that they occupy. By now, I hope I have made it clear to the people whom I interact that brain is not an organ where one person does a thing. All the actions of brain are done in totality by different area combination. So if one area is performing less, then the other areas would come together and take the functional reserve of the underperforming. Now during sleep, what happens is the visual input gets less and visual imagery gets less important. So the brain's functional area allocated to the visual sensory perception is facing tremendous competition from other sensory modalities which are working to take over the visual sensory area. And for that, brain needs to keep the visual imagery area highly active. This is the basis of profound visual dreams. Again, this theory has its lacuna, its strengths, and its criticisms, but I am not going into that. The third part is reflex. There are various inherent reflexes pathways in brain, most of which we don't even consciously perform. These reflexes during central autonomic activation of REM sleep gets triggered and we perform the cognitive equivalent of the motor action that we perform during day. Again, this is a viable theory, but we don't have good proof. What we have is some proof, some strength of this theory, some lacuna, and some criticism. So these are the three theories which are partially proven and each actually has some proof now. If I may give my opinion, which would be opinion only because there is no proof yet, all these three are interrelated in forming our dream structure. So this is the what. How I am not going to explain now, I am going to explain later. When is a very interesting thing. I would go to when in my last slide of 2. So is dream a single monolithic structure? It is not. There is lucid dream, there is REM dream, there is NREM dream, there is nightmare, and each of them has their own pathophysiological basis and brain mechanics, and each are different. Lucid dream is very much different from REM dream. REM dream is slightly different from NREM dream. And all three are very highly different from nightmares. The pathways, the large-scale cerebral networks, the involvement of them, they are very much different in all four categories. So dream is not a single monolithic structure that our cocaine sniffing forefathers have taught. So I would go into lucid dream and other phenomenon with same pathological basis into more details, because REM sleep dream, Nrem sleep dream, I cannot hope to explain in 25 minutes. The lucid dream is also hypnagogic hallucination, is also hypnopompic hallucination, is also REM behavior disorder. The basic pathophysiology of these four things are a spectrum. If we think like a spectrum, then from lucid dream to REM behavior disorder, the level of awareness of autobiographical process, the sense of autonomy, gets sequentially decreased. But otherwise, these four systems are same. The same pathophysiological basis, the same neurocircuitry involved, but the self-awareness and the awareness of the person who is dreaming is not same in lucid dream, in hypnagogic hallucination, in hypnopompic hallucination, and REM behavior disorder. Here, the dreamer is aware of the dream content vividly in all four. Dreamer is aware of the physical world in all four. The dreamer remember the dream content fully, but depending on the autobiographical process and awareness to the physical world, the dreamer reacts to the physical world in a range of responses. In lucid dream, the dreamer does nothing. In hypnagogic hallucination and hypnopompic hallucination, the dreamer reacts sometimes to external environment, and sometimes the reaction is very disturbing. In case of REM behavior disorder, there is always a violent response to the dream content in external. So what are the processes involved in this phenomenon then? Number one is arousal promoting circuitry. Number two is autobiographical memory and learning circuitry. And number three is incidental memory and learning circuitry. And now actually the complex things beginning. I hope I am not going to confuse you. So autobiographical circuitry of this is very simplistic schematic. This is actually a schematic from, let's say, 2000, 2001 concept, but it's still somewhat valid today. And if you don't want to remember a lot of autobiographical things, this schematic would actually give you some understanding. The lateral cortex is more into autobiographical, emotional, spatial, and the verbal aspects of self. The medial cortex is self-referential, that is the what constitute our full self, the basic self. And sensory processing or sensory cortex is body self. These are the various areas which constitute midline cerebral structure. I don't want you to remember all the names, just remember these things. That these structures are situated medially and just above the lateral vertebra. And their importance is whenever the dementia symptoms appear, these are the areas, these sit. Is medial orbital prefrontal cortex, posterior cingulate, anterior cingulate, rostral. These are the areas which are affected first. So the sense of self is disturbed in dementia symptom first. And in case of lucid dream, these areas connection determine whether that lucid dream could manifest as hypnagogic manipulation, hypnagogic or hypnopompic hallucination, or lucid dream, or REM behavior disorder. These are the functions that are done by midline cortical structures. Now, autobiographical memory followed by incidental memory and learning. Now, this is a very schematic representation of memory and learning. First, we get information from environment. Then that creates some sensory memory, and that memory is either incidental or intentional acquisition, followed by working memory. Working memory causes cognitive process activation, as well as goes into long-term memory, abstract knowledge, core knowledge, and other things. These are the various areas of brain which are involved in incidental encoding in older adults. Prefrontal cortex, parietal region, right dorsolateral prefrontal cortex, posterior cingulate, precuneus, temporoparietal junction. These are the areas. I don't want you to remember everything in the slide. Just remember these are the various areas: frontal areas, dorsolateral prefrontal cortex, and temporoparietal junction. Now, arousal promoting brain networks. Again, there are three regions which are interconnected. Anterior cingulate and medial frontal cortex connects with upper brainstem, and precuneus, posterior cingulate, and retrosplenial cortex, they connect with brainstem, and they connect, these two areas connect with each other. This forms the basis of three arousal promoting circuits. There would be various neurotransmitter names there, but I am not going into neurotransmitters today. Neither I am going to molecular psychiatry. I would limit myself to only connectomics today, and that too just superficial. So these three interact and produce the general framework for lucid dreaming, REM behavior disorder, and hypnagogic hallucination. If the sense of self is grossly disturbed, specifically like neurodegeneration, then REM behavior disorder would be more. And if the sense of self is extremely preserved or adequately preserved, then lucid dreaming would come. Hypnagogic and hypnagogic hallucination would come in between. That's why if you see in your practice patient book, you would find that the young people, they are complaining lucid dreaming more, and it is usually a self-complaint. And the older ones in whom you can suspect a neurodegeneration are coming with problems of REM behavior disorder. This is another important thing. Arousal not only means arousal promotion of arousal consciousness, arousal from consciousness. Arousal also involves these things. I am not going to give the correlation of these. You can understand the correlation yourself. This is just a schematic representation of the neurotransmitter involved, but today I am not going into details of it. The second one, and the most interesting one today is nightmare and night terrors. Nightmare and night terrors both have same neurobiology, but different expression. The basis of theirs are central autonomic grid hyperactivity and vestigial brain reflexes. Whenever there is central autonomic grid hyperactivity, there would be chance of increased nightmare and night terror. But nightmare is part of REM sleep, so it would be vivid, it would be visual, and it would have very accurate representation of the theme. In case of night terror, as it is a Nrem phenomena, the accurate representation would not be there. It would be mostly a theme representation and primitive representation, and the dreamer won't be able to recollect. They would only show the increased autonomic grid hyperactivity. Now, what is central autonomic network? Central autonomic network is the brain structures which control activation of the autonomic nervous system of body. Brain controls whole body through four large systems. One is autonomic nervous system. Number two is immune and coagulation system. Number three is neuroendocrine system, and number four is somatic nervous system. Now, the central component which controls the autonomic nervous system is central autonomic network. Anterior cingulate, insula, thalamus, hypothalamus, amygdala, periapodictal gray, parabrachial network, nucleus, locus coeruleus, rostroventral medulla, podoventral medulla, nucleus tractus serratorius. All of these are part of this grid. This is the grid which determines fight or flight reaction. This is the grid which determines prolactinemia in response to antipsychotics. This is the grid that determines TSH rise in response to various body and environmental stress. This is the grid that determines panic attack and other things. This is a very simple schematic representation, but the actual picture is much more complex. This would be the first component of nightmare and night terror. The second component is human vestigiality. Human vestigiality means a range of vestigial behavior that is shown by human beings which they acquired in their evolutionary past. Human vestigiality is part of evolutionary biology. It channelizes the autonomic activation, induced brain activation into various themes. So what are the various vestigial reflexes? These are some cerebral and spinal reflexes formed during evolutionary past. They are not needed by human beings now. These reflex pathways still persist in brain and CNS. They activate during central autonomic hyperactivity in Nrem and Rem. And whenever the person is in under cerebral stress, these activation would be more. That's why anxiety patients, anxiety is early stage of cerebral stress response failure. So in anxiety, nightmare is more. This is actually the first vestigial reflex that is seen in human being. Hypnic jerk, as well as the theme of falling from something or drowning in something.
Bhaskar, 5 minutes.
Yes, 5 minutes would be enough. Whenever this vestigial reflex activates, the person feels they are falling from something or they are drowning in something. This originated from that stage of evolutionary past when human being was a tree-dwelling mammal. Then the second reflex comes from those time when human being was the bottom feeder in earth ecology. Just started bipedal walking, but had no evasive manners from predator. In this theme, people experience they are being chased by something, they are being haunted by something and someone. The theme remains the same, but the manner of dream would be dependent on the experience, life experience and learning of that specific person. The third one is being lost in something or losing something or someone near dying. The same thing. This started when human beings first started gathering together and forming small families and groups. There are other vestigial reflexes which represent other themes, but again, I am going to a bird's eye view today and cannot go into details. Now, this is the last part. So, by now, we have understood that brain regions determining all these things, they are nearly similar. So, why should the visual experiences be different? The visual experiences and visual aberrations we experience during our cognitive journey, be it hallucination, be it dream, be it misconception, be it other illusion, be it imagery, they have a common neurological substrate, and the network of imagery contributes in all these things. So with this, I am ending my presentation. Sorry if I confused you a bit, but this is the bird's eye view I can offer.
Thank you, Bhaskar. There will be questions asked later. I think Jagjot has a couple of questions to ask. Over to you, Dr. Manjari, for your talk.
Yes, thank you, sir, for the introduction, and thank you to Bombay Psychiatric Society for giving me this opportunity. So my talk is, of course, very different from Dr. Bhaskar, and I will be speaking on sleep disorders in children and adolescents. So I also practice exclusive child psychiatry, and sleep issues are something that come to us very, very frequently. And I think it's only worsened during the last 1.5 years since we have been in the pandemic. So the scope of the presentation, what I will try to cover up in the next 25 to 30 minutes will be speak a little on sleep physiology, how it differs in children from adults, types of sleep disorders, some common case vignettes that present to us, how is sleep problems and ADHD interrelated, how does the sleep get affected in a child with pervasive developmental disorders, especially autism, and specifically a little on sleep disorders in adolescents, because I think this is a very important part in adolescent psychiatry. and a little on COVID-19 effects and an overview of the treatment of all of this. So to begin with, one of my favorite quotes is, that we are not much sicker and much madder than we are is due to exclusively that most blessed and blessing of all natural graces, that is sleep. So sleep is something that we often undermine. However, it is extremely important, and not only in adults, but more important in children for them to live a normal life. So the typical human being, if we look at it, spends a full 1/3 of their lifetime asleep. So I think it is very important to know a little bit about sleep. I'm a mother to a 2.5-year-old child now, and I think only in the last 2.5 years, especially the first year after my kid was born, did I realize the importance of sleep. So I think to every mother, her child sleeping peacefully could be the biggest or her best dream. So they often say that the child first steals your heart and then they steal your sleep. And I think this is very much true. So every mother waits for that time when the child can sleep peacefully throughout the night. So begin with the sleep physiology. This is an overview of the sleep physiology. Won't be going too much into details. However, would specify how it is different from adults in children. So we all know that we have stages in sleep, NREM and REM. So NREM has 3 stages, and the first stage is between wakefulness and sleep, which is the shortest stage. It's during the second stage that the body temperature drops and the heart rate begins to slow down, and the brain begins to produce sleep spindles. This lasts around 20 minutes. During stage 3, the muscles relax, and this is the deepest sleep. REM sleep, of course, rapid eye movement sleep, is when the brain is more active, the body becomes relaxed, immobilized, and dreams occur. This is also when a lot of parasomnias occur during some of these stages. So if we look at it, the duration of all these phases during the entire sleep cycle or during entire night, this is how it happens. So NREM basically takes up 75 to 80% of our sleep, while the REM sleep is about 20 to 25% of the whole duration. So how do children sleep differ from adults? Children have more frequent REMs. The REM sleep comes a little earlier in children. The total number of hours of sleep are much more in a child than in an adult, and it is maximum when the child is just born, when it's an infant, and it decreases across the lifespan. The length of a sleep cycle is much shorter in infants. So initially the length of every cycle, that is the NREM, is about 45 to 60 minutes. And then it increases to match that of adults, which is 90 to 120 minutes. So sleep recommendations by it. This is a very common question that we do face in clinical practice. Doctor, how many hours should my child sleep? Or how many hours is it essential? Or is my child sleeping enough? Or is my
Anjali, are you sharing your slides? Because we can't see a single slide.
Yes, something much.
Yeah.
Is it visible now?
No, ma'am. Can you share your screen?
Yeah, I've started screen sharing.
I thought you were talking extempore.
No, so I have a presentation.
No, nothing is visible.
Now?
No, ma'am.
Yes, yes. No, no.
No, we can't still see.
Is it now?
No.
Ma'am, can you again do that, or can you share it with one of us? We'll start sharing the screen.
Just one second. Is it visible?
No.
Should I then send it to somebody? Because it says for me the screen sharing is failing. I don't know why. I'm using a laptop only. But...
Okay, send it to Cheryl. Cheryl?
Yeah. Sorry for that. Yeah, it says it's now started.
No.
No, ma'am, we still can't.
Can you just give me a minute? I'll send it to
Yeah. Send it either to Priyanka or Kathy. Or Cheryl.
I will WhatsApp you my. I'll give you my email.
Yeah. Dr. Priyanka, can you please send me your email address?
Ma'am, I put it in the chat to you. Can you see it on the chat of Zoom? It's a personal message.
Yeah. Yeah, I've sent it.
1 second, I'm just accessing.
Yeah.
Ma'am, I've yet not got it. Just a minute, I'll just figure it out.
I think. 1 second. All right. Did you? Got it? No?
No, I've yet not got it in my mail. I'm just
Okay.
checking it again.
I think we can continue with the extempo part until the presentation starts. It's a basic about sleep structure, REM and non-REM, if you don't mind.
Yeah, I just want to see if she's got it.
Yeah, Manjari, why don't we just go on? Yeah,
Get it right.
she'll catch up. Yeah.
I'll just start
Sure.
sharing.
Yeah. Yeah. Yes, I was just saying about how children's sleep differs from adults. So in children's sleep, the number of REMs is more. The REM also occurs a little earlier. The total number of hours that children sleep is much more than in adults. And the length of a sleep cycle also changes. So the length is a little shorter in infants, which is about 45 to 60 minutes. And then it goes on to 90 to 120 minutes in adult, to match that of adults. The sleep recommendations by age. So as I was saying that we get this question very commonly, how much should my child sleep? And that depends on the age of a child. So say an infant up to 1 year of age, a minimum period of 12 to 16 hours is recommended. This then goes down as the child starts attending school. So typically a preschooler sleeps about 10 to 13 hours, which includes their daytime naps. A school child of 6 to 12 years sleeps about 9 to 12 hours. A teenager ideally should sleep 8 to 10 hours. However, I think most teenagers don't get this amount of sleep, and an adult generally sleeps about 7 hours a night. Then the REM sleep decreases. So babies have an REM sleep that is 50% of their total sleep duration, and this reduces to older adults. That is only about 20%. So as babies become adolescents and then become adults, the REM percentage reduces from 50% to match that of adults, that is 20%. I think I would need the slides after this. Priyanka, have you? Yeah, thank you so much. Yeah, so the things that go wrong with sleep are when a child sleeps too little, sleeps too much, has a broken clock, that means the timing of the sleep is disturbed, and things that go bump in the night, which are basically parasomnias. Next, please. So the classification of sleep disorders, to classify it very simply, not using DSM here, the sleep disorders are classified as either dysomnias or parasomnias. Dysomnias are sleep disorders that that have an issue with the timing or quality of the sleep, that is the amount of sleep. So the number of hours is either reduced or increased, and the timing changes. Whereas in parasomnias, the quality, the quantity, and the time of the sleep is essentially normal. However, there are disorders that intrude into the sleep. So you have parasomnias, which I will explain a little later. The next slide is just a DSM-5 classification. Won't want to go into details here. I'll be speaking about more of insomnia, especially children affected with ADHD and ASD, and parasomnias, which are the REM and the NREM sleep disorders. So the next 3 slides are basically case vignettes. So these are some common cases that present to us in a child guidance clinic. So there is an 8-year-old boy who's been diagnosed, confirmed with ADHD, attention deficit hyperactivity disorder, mixed type. He's on occupational therapy since about 6 months. He's also on tablet methylphenidate, takes it about 10 mg twice a day. The child has shown good improvement overall with regards to his hyperactivity, inattention, impulsivity. His school grades are better. There are no complaints from school as of now. However, of late, the sleep is becoming an issue. So the mother says all is well, but he sleeps very late, gets up multiple times in the night, due to which he's unable to wake up for the first class. And now even with online schooling, their school starts around 7. So the mother says he just can't get up. So the attendance is becoming an issue because he's typically always missing the first 2 periods. Then the case, a second case where a small child, a 2.5-year-old child, we're seeing a lot of children with developmental delay, especially over the last 1.5 years. This child presented with typical symptoms of autism like lack of response to name call, no meaningful word, not giving eye contact. On thorough evaluation, he was diagnosed as autism spectrum disorder. This child was also started on occupational therapy. He started showing good response and started responding to name call, etc. However, the mother is now increasingly distressed as the child is having multiple sleep disturbances. She says he sleeps very late, he gets up multiple times in the night, and he also gets up very early, due to which the entire family household is disturbed. The mother is unable to sleep. This has led to irritation and increasing tension among the family members. The next slide, please. This case vignette 3 represents, I think, the most common case that we are seeing is a teenager, typical teenager, 15-year-old boy, presented last week, said he has excessive daytime sleepiness, complains of not feeling fresh, feels tired throughout the day. The boy read up online about these symptoms and he diagnosed himself as clinical depression. He straight came and said, "Doctor, I have clinical depression, please do the needful." On further evaluation and checking about his sleep pattern, the child has been engaging in online games in the lockdown. The parents did not allow him to play beyond 10 p.m. as a rule. So when the parents slept off, he would manage to sneak in one of the parents' phone or get his access to his own phone and then start playing around 11 o'clock. When I asked him why specifically this time, he said it has to match with the international players. So he would play around till 2 o'clock, 3 o'clock in the morning, and of course be unable to wake up the next morning, due to which couldn't attend college, was very irritable throughout the day, and had a lot of mood and aggressive symptoms, according to the mother also. They all were worried and thought he has depression. Next, please. So what are pediatric sleep disorders? And what is the frequency? So the frequency is 1 in 4 to 1 in 2 kids aged 1 to 5 years. When they are younger, they do have some complaints. Complaints range from bedtime resistance, not wanting to go to bed, anxiety, obstructive sleep apnea, and narcolepsy. Sleep disorders interfere with daily patient and the child and the family functioning as a whole, as you could see in the case vignette. It causes significant emotional, behavioral, and cognitive dysfunction. And these are more common in children with neurodevelopmental, medical, and other psychiatric issues. Next, please. So a lot of studies have been done on the effect of sleep disruption. So how does sleep disruption affect a child? Academic deficits have been found, learning problems have been seen, and symptoms that almost mirror ADHD. On psychological testing, their computational speed, verbal fluency, abstract problem solving ability, to the point where even the IQ scores in children with severe sleep fragmentation have been found. Next, please. So these are just the elements of a detailed pediatric sleep history. This is almost similar to what we would take in an adult. However, I think in a child, the sleep environment and the pattern of the sleep, what exactly the child engages in just before going to bed, and what is the routine like throughout the day is very important to be asked. Next, please. This is an example of the sleep-wake diary. So just as in adults, we expect them to maintain a sleep diary. Same way in children, especially informing the parents to make this kind of a diary, to note when the child wakes up, when the child goes to bed, if the child is having nightmares or night terrors, at what time is the child getting up. This kind of a sleep diary will help us to understand the child's sleeping pattern a little more. Coming to parasomnias in children, they are of two types. So parasomnias are anything that intrude during the sleep. So they are divided into NREM and REM sleep disorders. Sleep terrors and sleepwalking is more common in NREM sleep. And between the ages of 4 to 12, these are extremely common. It occurs in about 15 to 20% of children. In sleep terrors, the child does not remember the episode. However, nightmares are dreams that occur during REM sleep, and the child can actually recall the dream after the child has woken up. Next, please. So what are NREM related parasomnias? They are either confusional arousal, sleepwalking, or sleep terrors. So about the prevalence is maximum in children between 3 to 13 years. So younger kids have more commonly these kind of disorders, and above 15 years, the prevalence falls to about 3 to 4%. And there is a stress model. So children who are, tired throughout the day, over fatigued throughout the day, when they try to go to sleep, the sleep is trying to get compensated. So they go into deeper sleep, which often causes parasomnias. Also, children who are being bullied at school or who are having some kind of environmental stressors, relationship issues, etc., they have more incidence of these kind of parasomnias. So we do check about the family environment when we check about parasomnias. REM sleep disorders, most common nightmares. Nightmares are very, very common between 6 to 10 years of age, and almost 5% of all children will have a nightmare at least weekly or even more frequently. The child remembers in most cases. So how do we treat parasomnias? Most parents say my child is talking in sleep, my child is walking in sleep, or my child is having dreams. So in these cases, the first thing that is informed to parents is good sleep hygiene habits, which I will discuss in detail a little later. But I think the most important thing to do here is to reassure the parents. In most cases, we do not treat these kind of parasomnias. Only in very severe cases, medication is considered. Giving them some kind of relaxation exercises before going to bed helps immensely. And most often, reassuring parents is the only thing that's required. Next, please. Often the parent asks, so if my child is having a dream or is walking around the house, should I wake him up? Should I wake him up and then take him to bed? If a child wakes up all of a sudden, sits upright in bed, or is even walking around, it is generally recommended to only talk quietly to the child, calm the child, and redirect the child back to bed. So except for an emergency case that may be causing some kind of physical harm, an attempt to awaken the person should generally be avoided, because the child can generally be talked to and taken back to bed. I think giving parents these kind of safety measures as to what they can do, especially in cases of sleepwalking, is extremely important. So locking or removing any dangerous items from the bedroom. There have been incidents where the child has, actually opened the door and gone out of the house, especially if they're staying on higher floors, etc. Securing the table side lights, using floor pads if they are having injuries because of repeated falling, installing alarms on the windows and doors, especially for sleepwalkers. And in case the child with parasomnia is displaying aggressive behavior, sleeping in a separate bed, especially separating the sibling, might be important. Next, please. So this is a very interesting treatment that this was actually developed many years ago by Barry Krakow and his colleagues. This is very beautifully described in a book on sleep disorders in children and adolescents. So just as in OCD, sometimes we do imagery rehearsal treatment, the same kind of treatment has actually been applied in children, and a lot of studies have been done and have found to be effective in children with nightmares. So basically it has 3 steps, that is confrontation. So this works obviously for older kids. So where you make them write down the nightmare because they can remember it, or draw the dreamy situation. Then help them to cope with that. So writing a new end to the dream. So if they're having a very bad dream and there is a very bad end to that dream, so writing a better end to that dream, and then trying to repeat that new dream per day for 5 to 10 minutes during the next 2 weeks. I haven't actually practiced this, but I've read up, and there are a lot of studies that say this is extremely effective in children with nightmares, especially in older children. Next, please. Next, please. So as a child psychiatrist, I think the most common disorders that I see are ADHD and autism spectrum disorder. Especially in the last 1.5 years, the number of diagnoses that I may have made for ASD has definitely gone up before the pandemic. So in most children with ADHD, I think in clinical practice, almost 90% of our children with ADHD do have some type of sleep disorder. And of course, the medications that we use for ADHD may also add to this problem. It's also seen that 25% of children who have severe sleep issues in infancy will later qualify for a diagnosis of ADHD. So sleep disorders can also be predicting a later diagnosis. So generally, they can have any variation in sleep onset. I'll rush through this so that I have time for the later slides. Next, please. Yeah, so I think the main treatment recommendations is first we psychoeducate the parent. Sleep hygiene, as I've been saying, is the most important thing to do. Lowering, if the child is on a stimulant, checking the timing and the dose of the stimulant. So many times we don't realize we've asked them to take the second tablet at around 2 o'clock, 3 o'clock, but because the child has missed that tablet, the parent ends up giving the tablet much later, and that might interfere with sleep, especially if he's using an extended release preparation, shifting him to a shorter acting preparation, or if he's using methylphenidate and we feel that's the main reason, we can try and shift to atomoxetine. Also, adding adjunctive agents like antihistamines, clonidine especially is very useful in children with ADHD and sleep issues. I think this is one of my personal favorites, and clonidine definitely helps in reducing symptoms of sleep disorder and also in ADHD. Next, please. So pervasive developmental disorders, talking about autism here, again, I think almost 80 to 90% of children with autism will have some kind of sleep difficulties, especially younger children, younger kids with autism, and those with more severe cognitive delays demonstrate more of increased sleep problems. And these sleep problems are more often long-standing. So for many years, they will continue to have sleep disorders if not treated in time. So typically the second case vignette that I described, where the child with autism was started on occupational therapy, was doing very well, etc. But because his sleep disorder probably was not being treated, his symptoms continued to worsen. So these children have insomnias, parasomnias, circadian rhythm disorders, sleep-related movement disorders as well. So it can be any kind of sleep disorder that children with autism present with. Next, please. So again, here sleep hygiene, as I keep mentioning, is the most important treatment. Melatonin has been found to be very, very useful in these children. So melatonin dose about 3 to 6 mg for a typical 4 to 5-year-old child, about 30 to 40 minutes before his bedtime helps immensely. Also, in some children, tricyclic antidepressants have been tried. Benzodiazepines are, of course, of lesser use in children. Antipsychotics like Risperidone, especially if the child is also showing behavioral problems and we are starting it for that, it may also help the sleep disorder. Next, please. So as I said, why I want to specify on sleep disorders in adolescents, I think adolescents definitely have a very deranged sleep pattern. And I think most of the adolescents that I sleep are not sleeping enough, are not sleeping on time, and a lot of mood issues start to rise after this. So the average sleep that is needed for an adolescent is about 8 to 10 hours. And can you go to the previous slide, please? 8 to 10 hours, but I don't think most teenagers are sleeping that much. So it's extremely common. About 60 to 70% of adolescents have some kind of sleep deprivation. That means they sleep much lesser than 7 hours. This definitely affects their mood. There is an increased risk of depression because of this. It's also shown to affect metabolism and cause obesity as a result. Cognitive performance gets impaired. Their attention span, I think the attention span of kids is very, very short nowadays. And I think when they sleep late or sleep lesser, the attention span, especially prolonged attention, gets affected very badly. Due to this, there is a decline in the overall academic performance, and there are a lot of physical issues as well. And most of these adolescents then start believing or thinking that they have depression. Next, please. So there have been increased reports of depression, anxiety, poor self-esteem, lethargy, feeling fatigue throughout the day, irritability. Due to this, to combat this, they start increasing their caffeine intake, they start increasing nicotine and alcohol use, which only worsens the problem. So I think sleep problems can be viewed as a potential easy marker for adolescents at a risk for developing some sort of psychopathology. So in adolescents with mood disorders, bipolar disorders, first checking for sleep disorders is essential. Next, please. Next, please. So what are the causes for sleep disorders? Why do adolescents sleep late? I think the first important thing is the voluntary sleep restriction, where they themselves decide to sleep lesser because they want to engage in online games, they want to watch screens, their friends are available to talk to them at that point of time. So most adolescents have a very poor sleep hygiene. Caffeine intake is very high in adolescents. Social media use just before going to bed. I think for most adolescents, that's very, very common to sleep with a mobile device around them. Screen use in late evening, a warmer room environment, negative association with sleep. So I have a lot of adolescents who keep saying, I just can't go to sleep. I don't think I need sleep. I think I can do with 3 hours of sleep and I can function really well. And generally, adolescents have a different sleep cycle from adults or children, that in them, the melatonin secretion happens much later. So ideally, they go to bed much later. And there is a slower homeostatic drive to sleep. This is biological reasons. And then adolescents worsen it with their sleep hygiene patterns. Next, please. This is a very interesting study that was done in Indonesia. Basically, this study was done to check the prevalence of sleep disorders in adolescents in relation to their screen time, especially during the COVID-19 pandemic. So I thought this was interesting. The prevalence of sleep disorders in adolescents is, as we know, very high. And this study proved that there is a very strong association between screen time and sleep disorders that occurred in adolescents during pandemic. Next, please. So we all know that adolescents have been, children and adolescents, the screen time has increased a lot, has increased immensely. So during the COVID-19 pandemic, children of all ages, I think even very young children, are spending nothing less than 6 hours a day on a digital device, because that includes at least 4 hours of their online schooling. And I think this was maximum 2 to 3 hours in the pre-pandemic era. So I think this is not new for us. Every child, every adolescent that we have been seeing in the pandemic definitely has increased screen time. So what are the effects of all this? So like I said, the association was very, very strong. A longer screen time has been definitely proven to be associated with delay of sleep and sleep latency and a reduction in the sleep duration. Also, this study proved that the presence of a TV in the bedroom of the teenager has been associated with a sleep disorder. So for many of us, it's very important to have a TV in the bedroom. But for a teenager, then that takes away his sleep restrictions. Next, please. So what are the mechanisms? Why this thing? We all know that screens are disturbing the sleep pattern, but why exactly? So when children engage in online games or any kind of screen, there is a lot of emotional arousal. If you see a typical adolescent playing an online game, they're all charged up, they're all excited, they're all moving about, etc. This emotional arousal, especially late evening, will interfere with sleep. The bright light that is emitted from the screen, we all know, contributes to sleep disorders. The electromagnetic radiation and a lot of physical discomfort. So a lot of adolescents nowadays are complaining of neck pain, shoulder pain, finger pain, etc. That is because of their increased screen time. Next, please. So also, as I talk about sleep disorders, as I said in the beginning, for any parent or for any parent like me, the sleep of their child, how the child sleeps determines my mental wellness or determines my mood the next day. So family stress and dysfunctional parenting can happen as a result of one child not sleeping well. The sleep pattern itself can be affected by the parent's discipline style. So many parents give in, okay, the child is not sleeping, start the screen, let him play, etc. So that kind of a parenting pattern will also add to their problems. A child typically not sleeping well means, especially if it's a younger child, will mean that at least one parent is not sleeping well, and this causes a lot of issues in the whole family. Next, please.
Yes,
I think, yeah, next.
There's a new data there.
Next, please. Yeah, so I think treatment-wise, pharmacological treatment, non-pharmacological treatment. Next, please. Yeah, melatonin, and parent education. So I'll just stress upon sleep hygiene. Next slide, please. Yeah, so we all know when a child or an adult tells us about poor sleep patterns, we tell them follow sleep hygiene. So what is this exactly? What do you tell a parent of a young child about sleep hygiene? So ideally, the parents, especially if it's a very young child, should take turns bringing their child to bed. This is important because there shouldn't be a strong association that only my mother should put me to bed. This has happened very frequently, where then if the mother is unwell or has an issue, the child just can't fall asleep. So parent taking turns to put their child to sleep. And active waking time. So making sure the child has sufficient physical activities and some kind of mentally stimulating and playing activities throughout the day. Help the child learn some sleep-related self-soothing strategies. So many times as the child wakes up, the parent rushes to the child. So waiting briefly, let the child try to fall back asleep is also important. Not hurrying back and lifting the infant or the baby at the slightest noise. So the child also should learn to soothe themselves and fall back asleep. These are tips for parents of very young children. Then these are very brief non-pharmacological techniques like parent education, of course, informing them about the amount of sleep, the types of sleep disorders, etc. Age appropriate and consistent bedtime. So having a same time that they go to bed and the same time that they wake up. Stimulus control. So a lot of children study in bed, play in bed, sleep in bed. So using the bed only for sleeping. This is stimulus control. Extinction. So if your child is crying, instead of rushing back to the child every time and soothing the child, trying to let the child cry it out and try to sleep on their own. Some kind of positive routine. So listening to some songs, relaxing music, chanting if required, doing some kind of light massage to the child helps immensely. I've seen this in my own child, and doing these kind of techniques definitely helps them to sleep better. A faded bedtime. So when children don't sleep till 2 o'clock, try to take them to bed just a little before they sleep. So you fade their bedtime and then try to get them as close to the desired bedtime. When children have nightmares, many times they frequently occur at the same time every night. So if you've asked the parent to record it on a sleep diary, many times you'll notice that typically at 3 o'clock, 5 o'clock, the child has a nightmare. So 15 to 20 minutes just before that time, actually lightly waking up that child and then putting him back to sleep does help to reduce the nightmare frequency. Cognitive behavior therapy, especially for teenagers, when they have sleep cognitions like I don't need sleep, I can't sleep, I'm just not able to sleep. So cognitive behavior therapy will help.
Dr. Manjari, towards you coming.
Yeah, I'm done. So just one last slide. Very briefly on medications, we know alpha agonists like clonidine definitely can be used, especially in children with ADHD and sleep disorders. Melatonin, like I mentioned, 3 to 6 mg, generally 30 to 60 minutes. It helps children to sleep faster. Antihistamines are commonly prescribed by other doctors as well and helps. Benzodiazepines definitely not much use in children unless the sleep parasomnias are very bad. Antidepressants like maximum, I think, tricyclic antidepressants, especially if the child has concurrent enuresis as well. Next. So I think that's it. I wind up in time. So thank you, and I hope all of us sleep well.
Thank you so much for both of you for an extremely interesting set of presentations. And now for some questions. There are questions written. Dr. Jagjot Singh asked both of you, or actually you, Manjari, which is the most commonly seen sleep disorder in children in your own practice?
Yeah, so I think in most, the sleep disorder that we see in children with ASD is delayed sleep. So they sleep later. They do have multiple interruptions. Behavioral insomnia, as it is called, is definitely much more common, is most common. Also, parasomnias are fairly common, even if we don't treat them. I think definitely a lot of parents come to us with when their kid has nightmares and night terrors. So I think these are very, very common.
Thank you. There's a question which Dr. Amita and Ashutosh have asked both of you. How do you determine the severity of parasomnias in order to assess the need to medicate?
Not to medicate.
No, to both of you. Bhaskar, would you know?
Let her answer.
So I think if the frequency of the nightmare is if they are occurring very, very frequently, so more than about 3 to 4 times a week, and it is disturbing the quality of the sleep, the child is not able to sleep again and causing daytime issues also, at that time, maybe we decide to treat it medically. And of course, if all the other techniques have failed.
Okay. Dr. Bhaskar, this is an interesting one. Congenitally blind individual will have dreams. If yes, will they be identical or different compared to somebody who is not visually impaired? Dr. Ashutosh.
This is a good question. Interesting question. Actually, if you remember, I was talking about 3 theories of dream formation. One of them was our brain areas compete with each other regarding the functional reserve of brain. So those who are congenitally blind, their optic areas, they are shared by other modalities of sensory response. For example, their auditory area, their smell area, means olfactory area, their touch perception area, these would encroach on visual area in these people. So yes, they would dream, but their dream would be more tactile, more auditory, more olfactory, and various other sense modality rather than visual. If a person was not congenitally blind, or rather blind, has become blinded after some period of time in life, then their dream would be partly visual, partly other.
Thank you. And before you go away, but Dr. Bhaskar, there's a question from Dr. Prashant to you. Can lucid dreams be induced?
Actually, psychologists worldwide are trying to do that, because as I showed in my last slide, that the common pathway for all hallucination, all nightmare, all lucid dream, and everything has imagery network in it. So if we induce lucid dream in a person, there is a chance that we can manipulate hallucination and these things. This is the theory. So psychologists are going dire for it, but so far no success, and there should not be any success.
Okay. Dr. Priyanka Kalra has asked, it would probably be Dr. Manjari, because you mentioned it. Please share the experience of using clonidine and its dosage that you have used.
Yeah, so clonidine, like I said, is a personal favorite. I've used it a lot, and I think clonidine works extremely well in children with ADHD when they have sleep issues. So I think we use it in, it's a 100 microgram tablet available. You start 1/4 tablet, and I think maximum half a tablet is required, but generally even with 1/4 tablet, the child sleeps well. I think the first 2-3 nights we have to inform parents, especially, that the child may sleep much more and may be drowsy throughout the day, but the child generally gets used to it. So I think 1/4 tablet is enough for the child. That's 25 micrograms.
Okay. Question again from Dr. Prerna Khan. Have you encountered nightmares or vivid dreams with melatonin in children? Because some adults report of the same while they have been put on melatonin.
No.
Not that I've encountered in practice. Generally, melatonin has been safe, and no side effects have been reported.
Let me answer here, because the thing is, melatonin doesn't increase nightmare. What it does is, it either not going to prevent the nightmare, or it would increase the vivid nature of the nightmare, because melatonin causes REM consolidation. So the sensory experiences during REM would be more vivid. They would not increase. They would not do anything else. But the person who are remembering nightmare would remember nightmare more vividly. That's all.
Okay. Fine. Okay. I think that's the end of the questions so far. There have been a lot of people who have said thank you to both the participants for your excellent talk, etc., etc. Both you have been quite a hit. The fact that it's almost 8:30 at night on a Wednesday evening, and there are still 72 or 73 people who are holding on, either signifies that hypnotism is at work, or that you guys are good, and we prefer to think of the first. And it's so nice that our extremely busy president of the Bombay Psychiatric Society, who has done 3 shows before coming to the 4th one, is now visible. Avinash, would you like to say something? Unmute yourself. Yeah.
Yes. Well, at the outset, I think, when we started this whole sleep psychiatry interface, the whole aim was to have one topic which was biological and one topic which was clinical. And I think you all have done a fantastic job. I, of course, missed Bhaskar's presentation, which I will get back at, but I attended half of Manjari's. So I think it was a very clear, crystal, fantastic approach that you all took forward. And I would, of course, want to thank you all on behalf of the Bombay Psychiatric Society for doing this. And Bhaskar, of course, we booked him around 2 months ago so that, he doesn't know. So, and, so thank you for being there. And everyone, I mean, it was not my choice, this was what people said, that you have to get Dr. Bhaskar and ask him to speak on neurobiology of dreams. So that is why, the topic was what people had suggested, and that's what we did. And a big thank you to Dr. K.C. Chawda. I mean, we cannot have a program on child and adolescent psychiatry without him being there anywhere around. So we had to have him as our chairperson. So, I mean, so thank you for, taking out the time and coming in. Before I say the last words, just 1 minute, Dr. Vaidehi from IPCA will just say thank you to us, because the IPCA is our educational partner in this program. Dr. Vaidehi, are you there?
Yes, doctor.
Yes,
I'm here.
So you have 1 minute to just say whatever you want. Yeah.
Yes, certainly. So at the outset, I would first like to say that it was extremely interesting sessions. The different aspects of urinology, which is the word that Dr. Bhaskar Mukherjee has said about, and all the aspects of dreams, it was really interesting. So it's very amazing to know how brain is so active during the sleep as well. And certainly also a very insightful and very realistic practical approach and management of sleep problems in children presented by Dr. Manjari Madam. So it is a pleasure for IPCA to be associated with such an eminent forum of Bombay Psychiatry Society. So I actually thank you from IPCA Innovex team for giving us this opportunity, sir. And in the coming times, we surely would be privileged to be a part and be associated with you all. It was a wonderful evening, and thank you so much once again.
Well, on behalf of BPS, there are just 2 announcements. Our next program is on the 15th, that is the next week, Wednesday. We are toying between a full program on dementia versus a panel on suicide. We have not yet finalized it totally. Both our panels and speakers are ready, but we are toying with which program to go with first. So that's the thing. And the sleep psychiatry interface 3 will happen 2 months from now on the 2nd Wednesday. So that will be November, the 2nd Wednesday. And there, of course, we will have a biological topic on chronobiology, because we feel that's important and it's not sort of spoken about much. And the approach to sleep problems in a female patient. That's what we will be talking about. So that's the whole thing. So on behalf of BPS, my secretary, Dr. Priyanka, Dr. Ami, and the entire executive committee, I thank the 2 speakers and the chairperson again. It's been an amazing evening. Thank you for being there, and thank you for always being supportive of us. Thank you.
Thank you, sir.
Bye.
Bye. Thank you.
Good night.
Good night.